Hey again, this is ZengoMD. We talk a lot about thyroid function here on the channel, and I have over a decade of experience optimizing thyroid function in my patients. One thing that's always true is that using TSH alone is an oversimplification of thyroid function. So let's look at the terrible truth about TSH and how we can use it properly to diagnose and treat thyroid underperformance. Again, please read the disclaimer below that this video is not in any way an attempt to diagnose or recommend treatment for you, the viewer, and this is really more part of the PracticalCME curriculum, but I have decided to release it to everyone, even though it's a little more in-depth than some of our videos, and probably won't be as cute or funny, if you think any of them are cute or funny. But even in our office setting, we never just look at TSH or even just the thyroid gland alone when assessing a patient's symptoms. That's always an oversimplification. So the approach has to be more global. So a thyroid can't be managed in a 10-minute visit because we can't even explain TSH in 10 minutes. Well, let's give it a try. The brain makes TSH, which stimulates the thyroid to produce more thyroxine hormone. This video applies to patients with hypothyroid symptoms or an underperforming thyroid. And to even be considered for that and get your TSH tested, you need to be already on thyroid treatment or have some of these symptoms. So when your thyroid is underperforming, you generally get one or more of these major symptoms. If you have any of these symptoms and you've not been tested with a TSH test or any thyroid assessment, then this is a good reason to get one. There are also some additional minor symptoms, which can definitely be caused by hypothyroidism, but also many other multiple factors can play a role. And also, the presence of thyroid autoantibodies is a huge reason to get tested. Do you know if you have thyroid autoantibodies? If not, you're not alone. Nobody has come to my practice as a new patient in over 10 years and has known their antibody status, until I drew it, unless they were already on thyroid medication. So when this column is in effect and the thyroid is underperforming, you will see an elevated TSH. Now, nobody's questioning the ability of a very low TSH to diagnose the rare situation where your thyroid is overactive. This often results in these symptoms, and this can really be a medical emergency. TSH is the best and most accurate test to diagnose hyperthyroid. An underperforming thyroid is not a medical emergency, but it's a huge drain on quality of life that many people suffer with for years or decades. To review, TSH is made by the brain, which stimulates the thyroid gland to hopefully make T4 if it's able. And if the T4 production is too low, it should trigger more TSH. If the thyroid is chronically underperforming, then the TSH will continue to rise over time as the brain has to keep working harder to get the gland to respond. Here are the standard establishment medicine guidelines. Some have moved the TSH cutoff down to 4.5 from 5, yet there are millions of symptomatic people with low thyroid symptoms who have TSH levels below this cutoff, who suffer for years before being treated. And look at the overall width of this range. Why is this range so wide? Why is the high end nearly 10 times the low end? Well, one way to see how precise a test is would be to look at its distribution. If the test is a good sample of the population as a whole, it would be a symmetric bell curve. However, the data on TSH shows a skewed curve like this. Let's put in the top and bottom end of the ranges, which are designed to exclude around 2.5% of the people at each end. But what happens when the normal pool includes people who have undiagnosed disease due to lack of consistent screening, or they're on meds that can diminish thyroid function or raise TSH, or the presence of autoantibodies, which attack the gland? And remember, we said nobody's getting those checked unless they're already known to be sick. By excluding these people from the normal pool, you would get an upper limit TSH of around 2.5 to 3. This would make all of these people candidates for treatment, or a whopping 25% of the population who could benefit from thyroid support. Look, I didn't just make this up. Over 20 years, the WICAM survey excluded those people from the normal pool, and they found that once you do that, and only test people who are proven healthy, you actually notice at a TSH of 2.0 or higher, the chance of developing true clinical hypothyroidism, the kind that requires treatment in the near future, starts to rise rapidly. This finding led to some major groups of traditional establishment physicians to abandon the 5 to 6 cutoff for TSH, as it was back then, and this included groups like the National Association of Clinical Biochem, the people that know about laboratory medicine. Also, the American Academy of Clinical Endocrinology advocated reducing TSH upper limit, and even the Endocrine Society has lowered the upper limit, but for now only in pregnant women. Not only is hypothyroidism in the future more likely as your TSH rises above 2, but the symptoms you are feeling right now start to appear in some people at around a 2.5 and escalate from there until 4.5. Here are a couple of examples. This study shows a continuum of obesity risk as TSH rises, even below the cutoff for hypothyroidism. The link between TSH and the elevations in the bad LDL cholesterol also rise above a TSH of 2.5, as this study points out. Note the mention that LDLs rise, quote, within the reference range, unquote. Therefore, it sounds like we need a new reference range, right? Too bad this study is 7 years old and nobody in the establishment has really listened and willing to move the range that low. It has trickled lower, but not that low. See, I've seen these changes in my own patients for 15 years, which is why I don't ignore these middle ground TSH levels that the establishment calls normal. So far we've hammered TSH due to its wide reference range, but is the test really accurate at all? And the sad truth is that while it's the best thing we've got, that it may not be as good as we think, and it can't stand alone, especially in stressed or chronically ill people. Oh, who's that? Everyone. We know that TSH made by the brain stimulates the thyroid gland to make thyroxine, or T4, and that production then negatively feeds back to the brain, hopefully to normalize thyroxine production and normalize TSH and establish an equilibrium. However, what happens in times of stress? It is well known stress suppresses TSH. It's all over the medical literature and the endocrinology texts. The components of the stress response also do this individually. That is activation of the adrenal cortisol response, as well as each of the catecholamine neurotransmitters. All are inhibitory on TSH. But the studies done on this response all involve short-term stress, which lowers TSH and results in an underproduction of T4. However, when the stress is relieved, everything returns back to normal, whatever that is for the person. But chronic stress is different, and it is the foundation of what our practice tries to minimize in patients. Chronic stress can keep TSH suppressed for a considerable time. Therefore, the thyroid hormone production will always underperform, and the TSH will look lower or more normal than it should. Therefore, in chronic stress, we believe TSH is lower, and therefore it becomes less precise. And in stressed individuals, like all of us, then we need a much lower TSH cutoff, or some other testing to run other than TSH. The same applies with chronic illness that produces inflammation. Inflammatory markers reversibly suppress TSH. But what if inflammation is chronic, as is found in some diseases, and when our GI tracts are subject to chronic processed pro-inflammatory foods, wheat, dairy? Yep, your fast food diet can lower your thyroid function, which causes symptoms, and then the gold standard diagnostic test may miss it. And that gold standard is only to test TSH and maybe free T4 in individuals who only have symptoms. And this process is why any patient with even a single potential symptom of poor thyroid function needs multiple data points, like these tests for thyroid function. But remember that outside factors influence the thyroid, and all of them need to be assessed as well. This includes all markers for stress, like cortisol, neurotransmitters, but also stress relievers, like changes in activity level, hidden stressors, like your GI tract, which means you need to look at the weather in the GI tract, which is your menu of foods that you eat, and a few other inputs we also check at our visits. And finally, the big one, the influence of prescription drugs. And that is why you need someone who knows pharmacology in depth to manage a thyroid. This is not the realm of the chiropractor or the naturopath. You don't manage a thyroid in a 10-minute visit, and you don't manage it with 2 input tests. People suffer for years or decades waiting for their TSH to cross 4.5. Or some are neglected and never get tested at all until their TSH is 20. I have had patients break down into tears when they finally learn the symptoms that prevented them from living their life to the fullest for the last decade could have been easily resolved with the right testing and treatment. TSH may be the best single test we have, but it's not good enough to be used alone. Make sure you have these conversations with your physician. When was your last thyroid tested? What symptoms do you have that are on the list? Or if you're already on thyroid replacement but the symptoms are not relieved, are there other tests maybe that could be used to help figure out what's wrong? Or are there other inputs that are being missed? Please check out our other video on wake up body temperatures, and make sure you subscribe to this channel so you're the first to find out when we have new releases. That's all for now. Bye.